I'm Dr. Timothy Johnston with Module 5 of the team training for producing an amazing customer service for your dental practice. We've been talking an awful lot about hygiene services and coming into how we think differently and how we can get communication going, have team meetings to help us think more similarly. Well, let's take it one step further. Let's get into some very specific clinical issues and find out if the doctor and the rest of the team are thinking the same. All right? This is my Synchronicity program. I developed it probably 15 years ago, and it has done more for my practice in terms of being on sync with my team than anything else I've ever done in my life. True statement. I think you'll find it to be as well. This is a module that comes in the middle of a lot of other training. It's also a module that we are giving away as part of joining our group and becoming students in the class with us. So you're right in the middle of the amazing customer service experience. I hope that this is a good representation of the kind of information and systems we're delivering, and that you'll come back and join us for some of the other content. Let's dig into this. So synchronicity, are you synced up? Treatment planning and synchronicity. Treatment planning, number one, we're doing full records, mounted diagnostic models if appropriate, if you need that. We're making a decision tree from there. Are we going to, every time I see any kind of a case, what is my decision tree? I've got all these things notated. What teeth do I need to remove? That's first. And all this comes directly from Pete Dawson, by the way. First thing, what do I need to remove? Get those out. Done. Next is, what can I move? Can you do some orthodontics to make a position of a tooth more favorable so that it makes your restoration easier? So remove, then move. Next is adjust. Is there anything you can modify? Maybe you need to go through an occlusal equilibration to get the bite straight again. So remove, then adjust, and then restore. That's the whole name of the game. Remove, move, adjust, restore. Then, if you need to replace something, you can. Implants, bridges, partials, whatever it may be. I prefer implants, of course. But if you'll do that decision tree every time, then you'll know what your treatment planning is going to end up as. I have people that fall apart on big cases. They don't know where to start. Start with remove, end with replace. There's your treatment goals. It'll flow. You can put together a whole thing in no time. Anybody know what that is who's watching? Hopefully the musicians all said middle C, and that's true. Why do we care about middle C? Because it's a tunable note. That's middle C on your keyboard. There's a pitchfork tuner. Every good piano tuner in the world, good or bad, doesn't matter, they have a middle C tuning fork. They hit it, and that sound that it makes is exactly what that note ought to sound like on the keyboard at the same time. It's a precision instrument. It measures a certain depth and width and length and made of a certain metal. If you produce that piece of metal the same every time, it'll sound like middle C every single time. All right. Why is it important? Because it calibrates all the rest of the keys. So what's your middle C? What is your tuning fork? Are you in sync? When you see all this, do you know where you're going? When you see a single x-ray, do you know where you're going? Does the doctor and the hygienist both agree with the doctor's diagnosis, or is there some disparity between the two? Let's have a little test. There should be somewhere in your packet, it might be coming up later, you can print it offline, or it may have come as a paper form. It should be included electronically. You're going to have a test form that simply says Synchronicity, and it has 20 entries on it with a list of things to do next to it. I will also include the list of things to do here on the bottom of every screen, like whether you restore it or replace it or remove it, with every single slide. So if you're taking this without the advantage of this sheet of paper, you can still play along. Just pause this for a moment and number your paper 1 through 20. Actually, 21, there's a bonus. Number it 1 through 21. And be ready. This is going to be fast moving. I'm going to click on the first slide. It's going to give you about 20 seconds to examine the information on the slide and come up with what you would treat it with. Are you going to replace the filling, crown the tooth, or leave it alone? I think that's the first one. After that, about every 10 or 12 seconds, not as much time as the first one, it's going to switch, and you'll hear the sound of like a camera clicking when the slide switches. Look up, decide what needs to be done, and move. You're not being given 2 or 3 minutes on each slide because we don't spend that much time looking at the teeth. If your hygienist is cleaning them, you do, but the exam part is really just get in, evaluate, decision, because we don't spend an hour looking at the teeth with an explorer. We spend 5 minutes, maybe 2 minutes. You got to be able to roll through there in seconds each per tooth. Here we go. If you're ready, I'm going to step off camera. This is going to come through only in video for you, and here we go. You'll still hear my voice. This is tooth number 18. There's no symptoms. The x-ray is on the left, it's circled. The fillings are on the right. Are you going to leave it alone, place a new composite, or crown it? Tooth number 18 again, no symptoms whatsoever. Are you going to leave it alone, new composite, or crown it? Number 13, there's no response, no symptoms at all. Again, the tooth is not responsive to the tooth sleuth. You leave it alone, new composite or crown. Tooth number 19, again, no symptoms at all. What's going on there? You leave it alone, do a composite or a crown. Same question, different tooth. Here's a real problem. This was done by one of our doctors 1 year ago. One of our doctors that is no longer with us. Another tooth number 2, no symptoms. What do you want to do for that? Tooth number 20, there are no symptoms at all. There's the x-ray on the left. Tooth number 3, x-ray on the right, no symptoms, patient was not complaining. What are you thinking? This tooth had no symptoms at all until I stuck an Explorer in there, gave it a twist, and the patient jumped. What do you want to do for that? Here's the diagonodent. The diagonodent reading is 27. What are you going to do for that tooth? The x-ray is inconsequential. There isn't one. What do you want to do for that tooth? Now here's a patient right there at the junction of 18 and 19. He's 25 years old and drinks 4 or 5 Mountain Dews every day. What are you going to do for that guy? Leave it alone? Put him on a fluoride regimen? Or go ahead and restore him now? Coincidentally, that looks just like the previous x-ray, because it is, but a different story now. This patient, we're going to say, is 19 years old, has really good oral hygiene habits, is not drinking sodas. Number 5, take a look just number 5 for a moment. Feel free to evaluate the rest of the mouth, but number 5 on the mesial, what do you do there? Now we're looking at the potential for periografts. Do you want to leave those alone? Do you want to place a composite restoration, do a gum graft yourself, or refer it out to a periodontist? No symptoms, no sensitivity. Different tooth, same question. Leave it alone, put a filling there, composite resin, do a gum graft or refer it out for a graft. Hygiene. Your probing depths are right there on the top line. And your bonus question, 65 years old, no symptoms, second visit to our office in 2 years. Just what do you want to do there? I didn't give you choices because I wanted to come out verbally. What are you going to do for tooth number 19? So, are you in sync is the question. If you were taking this test with your doctor, well, let me back up. If you weren't, stop this tape, stop this presentation, rewind it to where we started, get your doctor and get him to come here and take it. Because the correct answer is your doctor's answer sheet. Whatever office you work in, whatever he said to all of those is the corrected answer sheet in your office. Now, his answers might be different from mine, might be different from my colleagues. It doesn't matter. There are some okay answers for all of them. There are some clinically wrong answers. We'll go through that perhaps. But if you're working in office and you agree with the doctor that just gave his answers, you're in the right place. If your doctor's answer sheet looks dramatically different and you disagree vehemently, you're not going to change him. You may as well get a new job, or you're going to be miserable the rest of your life. That's an honest statement. Sorry, but it's true. At this point, in a live audience, I always get requested to please go through the slides again and tell you what my answers would be, and I'll be happy to do that here because it's appropriate. So let's start with number one. This needs a crown. Let's talk about my criterion. In my office, everybody knows my criterion is if the tooth is going to be 50% filling when we're done, that needs a crown. Or if there is a broken or undermined cusp, that's going to need a crown. So when you evaluate this, you see that all that amalgam has completely undermined that cusp. This cusp is already gone. That's already strike one, strike two. And plus, once I finish with all the decay removal, if I were just to fill it, or I put my core in there, that'll be more than 50% filled. So 3 strikes, you're out. Any one of those would have been enough for me to say, this needs a crown. This tooth, honestly in my practice, I probably would not treat that tooth. Because let's look at it. There's no decay visible under the filling on the x-ray. And these are not cavities. These are just areas of staining in the grooves where the secondary anatomy wasn't carried through with a little extension for prevention. If that was an amalgam, I'd have a different story because amalgams are always leaking. If it looks like that up here, it looks 10 times worse underneath. But composites are bonded to the surface. If I'm not able to get an Explorer to stick in there, I'm not going to do it. And a diagnodent cannot give you a reading here because diagnodent always reads 100, the maximum, as soon as it touches any kind of composite. Even just whatever resin might be left over in there, it's going to throw the scale off, so you can't use that. Clinical experience says I'm probably going to leave that alone. Would I be okay if your doctor said I'd replace that? Sure. A matter of standards, it's okay. I tend to be erred a little bit to the side of caution, a little bit less aggressive perhaps. I'd let that go. Any change, we'd take a picture of that. And we would monitor that. And any changes going forward, if it's a bad change, we will certainly go ahead and restore it at that point. Number 3, no symptoms, and it's not responsive to the tooth sleuth. That's to throw you off. I don't care if it's responsive to tooth sleuth. He's got a big crack. That filling is about half the tooth and a nice sized crack running right off that off the mesial side of the tooth. Additionally, it looks like that's going to have to be restored as well, back there where it touches up against that molar. But clearly, in all that staining, shading under here, that's all decay. 50% rule, it gets a crown. Number 4, tooth number 19, there is an area of decay there. Only 2 things look like that on an x-ray, either active decay or a cement line. But a cement line, which we'll see in the next slide, looks very uniform, very flat. This is a little bit fatter, thicker, and this patient has already had one time. That restoration under the crown right there is where there was decay once upon a time, and that was repaired. Now there's a second strike of decay under it. That crown needs to come off, clean up the decay, a new core, and a crown. I might also want to mention to the patient its possibility of root canal. In fact, I would take another x-ray to make sure I could see the tips before I started. That's just a bite wing. I'll have a PA before I ever touch a tooth with a crown prep intention. So I'd find out because that's really close to the pulp right there. Next up, here we go, number 20, same idea. If you're looking at that or that, I could have pulled either one. I would call both of those cement lines. Look how nice and uniform and flat they are. If you're using a non-radiopaque or radiolucent cement, that can show up as what looks like decay, but it's not. And the uniformity of that is what gives it away. Tooth number 18, oh boy, this is tough, isn't it? Crowned by your own doctor less than a year ago, open margin. What do we do? I mean, that's an open margin. That should have been sealed. I guarantee this doctor would have had a successful run at this if they just adjusted the mesial contact. It would have sat down all the way. Instead, I'm sure they ended up adjusting the occlusal because they thought they were down all the way. Well, what do? You replace it, no question. And at what charge? 0. That was my office. It was one of my associates who was there. The associate has since gone, otherwise they would have done it themselves. I took care of that myself because that's the right thing to do. That is the proper, what? Customer service to act upon. Number 2, no symptoms. What's going on here? Nothing. That's just an old amalgam. That's how old amalgams look. Tell me that's decay? I doubt it. Little crevices up around it? No problem. Even there, just rough. Now, if your doctor wants to take out every single amalgam that doesn't still look shiny new, that doesn't have that appearance like right there, okay. I think that's a little bit over-treating. But again, your doctor makes the rules in your office, and it's all right. I'm a little more on the conservative side when it comes to replacing things. Now this number 2, different story, no symptoms, doesn't matter, felt sharp because the cusp broke off apparently last week. One cusp gone, we're going to replace that with a crown. Right? There's probably also some decay up there. It's awful lot of gray up under there. Tooth number 20, no symptoms. It is already more than 50% filled. And the only reason there's not symptoms is because this patient clearly does not floss. Because if he or she flossed, that little broken piece of tooth right there would have at least caught their attention by now by shredding the floss or possibly even have flicked out. Either way, once you replace that huge composite resin and add in the restoration that needs to happen here, that MOD will be bigger than 50% of the tooth by far. That tooth gets a crown. Tooth number 20, no symptoms. What do you do for that tooth? Nothing. What is that? It's not a cement line because that's not a crown. That is an adhesive line. So your adhesives are not all radiopaque either. You should probably know that. And if it looks like that from another office, you can assume it's just an a thick layer of bonding resin, adhesive line under there. It's too uniform, straight across, just like that cement line was, to warrant calling it a cavity. Decay always happens the same way. It'll come in small, ends up big in here. That's not that. That's an adhesive line or a bonding resin line. So leave that alone. Number 3, no symptoms. X-ray looks good. Filling looks good. Am I going to do anything about that? Maybe a little chewy there, but again, not decayed. Nope. And that's what happens in our office every day, right? You go through hygiene, you think, boy, that's some big amalgams. But there's really nothing wrong with them. Keep on moving, especially if there's 8 of those in the mouth. If all 8 molars have that, do you really want to tell the patient, you need all of those replaced with crowns today? No, but there might be one, or pick on the worst one and start down that path so you can get them out of trouble before trouble ever happens. No symptoms until we stuck an Explorer in there and gave it a little twist. What does that mean? It means that is the beginning of cracked tooth syndrome. That tooth needs a crown as soon as possible. Tell the patient not to bite down on that side of their mouth until you see them, and warn them that 10% of these teeth end up needing a root canal, and 10% of those teeth, or 1% of the originals, end up coming out at some point because the crack was more invasive than it appeared to be. If it hurts not at home, but when you give it a little twist, you get CTS, cracked tooth syndrome, and you're going to end up with a crown for sure, maybe a root canal, possibly an extraction. Oh, and why is that happening? Look what he's beating against. There's an implant there. I guarantee you these 2 teeth were left in full occlusion when everybody who does implants ought to know that that implant tooth should be left slightly out of occlusion. Why? Because all these other teeth have ligaments that will give a little bit when you squeeze on them, and the implant does not. So when everything else gives a little bit, this acts like a ramrod and hits the opposing tooth. That, left in occlusion, will break the opposing tooth. And many implant dentists don't adhere to that. They were probably taught it. Maybe not. Not everybody goes to great courses either. You got to have an experienced dentist to do that. Tooth number 15, the Explorer does not stick. So there's no stick there. We put a diagonal and got a highest reading of 27. I picked that on purpose because below 20, everybody knows is not a cavity. Above 30, it's a cavity. 20 to 30 is a gray zone. Use your clinical judgment. So my answer here is use your clinical judgment. I'm not going to give you an answer because I'm not poking around that mouth and looking with my loops on. At a 27, I will often say, let's look at it again with the diagonal dent in 6 months. And if it's a 30 then, or even a 29, it's getting worse. Let's move from there. Number 14, anybody know what that is? Give you a second there. Any doctors? That is silicate cement. That's not composite resin. It will be there until the cows come home, and it will be yellower and yellower every year until it looks like a corn kernel's been stuck between 2 teeth. Anything wrong with it besides being ugly? The answer is no, and he's got a few of them. That might be leaking a little bit there, but I'm going to tell you, silicate cement restorations from before the 70s, before the late 70s, they last forever. They're ugly as sin, but they last forever. I have a very specific mantra that I tell these patients. I'll say, Joe, Mary, whatever. I'll say, you know that filling up front there doesn't look so pretty, but honestly, it's functional, it still works. If you want to leave it there, that's okay, but you got to promise me one thing. They look at me like, what? I said, you just can't tell anybody that I'm your dentist. That always gets a little chuckle out of the patient. And it kind of plants the seed too, like, I can do better than that. So this is a composite, not very well done on shade matching. We could certainly bring that up to be perfect and beautiful and match all day long. Let's see. Oh, here we go. Same x-ray, two different scenarios, right? This patient is 25 years old and drinks a case of Mountain Dew every day, or a six-pack of Mountain Dew every day. What do we know about this person? They're not going to change their habits, and those cavities are going to get bigger. Let's look at those cavities. What are they? I'd call those incipient. Unless it's more than halfway through the enamel, the definition in the textbook is incipient. So do you fill incipient? Do you watch them? Do you treat them? In my office, it depends on the patient. Drinking his weight in sugar every week, we're going to go ahead and fill those because those are not getting better on their own. Same x-ray, but let's pretend it's a different patient. 19 years old, still kind of young, hasn't formed his habits yet, but has good oral exams, is not drinking a six-pack of soda every day. What do we know? These are two other cavities, otherwise fairly clean, nothing else going on. Incipient has a really good chance of responding to some fluoride therapy. So I would put this kid on fluoride for a year and recheck that x-ray in 12 months and see what's happened. We can always fill them then. If nothing else, they might even get better. They might regenerate the enamel with the fluoride treatment. What about this? Another case of that. Number 5, mesial surface. Incipient at best. I mean, there's barely anything there. There's a little cavitation, barely there, maybe a little something going up on number 6 distal, but I'm looking at 5. In that kid's mouth, I would have gone ahead and treated that with fluoride too. But look at this mouth. Decay interproximally, kissing cavities interproximally everywhere else. What do I know about this? It's only going to get bigger, so we treat that one too. Look at the whole patient. Look at their habits. Look at what's going on in their mouth before you decide. Perio issues. Here's some stuff. All right, teeth numbers 28 and 29. The probigs are all less than 3 millimeters, so there's nothing unhealthy here. No x-rays, don't need it, and all that. What's missing from here is the question. Are you missing gums or are you missing tooth structure? Here, you're missing tooth structure. In fact, it looks like it might have been drilled out once and restored, and those have popped out. But nonetheless, your gum line here follows the right contour and is all where it's supposed to be. If you take, I lost my drawings. All right, if you take a perpendicular line to the long axis of the tooth. So here's your long axis of your tooth, and you draw a line perpendicular to it, at an X, at the point lowest or closest to the gum line through either papilla that's closest to the gum line. So this would be our lines, be there and right there. And you measure 3 millimeters down towards the apex of the tooth. That's as far as you will ever get gums to grow. Let me say it a different way. You will never get gums down here to be any closer than 3 millimeters away from that going down. So 3 millimeters from there is as far as you're getting gums. So I'm already 3 millimeters. If I raise those gums up to here and I'm like 1.5 millimeters away, what's going to happen to those gums? They're going to recede right back down to their normal resting position. 3 millimeters is where you're going to end up, no matter what you do. In fact, in this case, if you did a gum graft, you'd probably end up with a worse result because this is already a little closer than 3. That's an anomaly. You go do surgery on it, you're going to produce the norm, which is a gum line down here. So you're missing tooth structure, and your gum grafting would have no effect. So you replace this with more tooth structure. Make it a microfill because the microfills have a little more flexibility. So when this person grinds their teeth, that's not going to pop out like the old ones did. Those are probably hybrids. I would use a microfill right there. Different scenario here. Now in this case, he's got his normal DEJ in through here, or CEJ, with some gum recession. Nice thick rolled borders, but it is recessed. If I were to draw that line, here's my perpendicular, or my axis of the tooth, and I draw a line from the shortest of these two papillas, there's the shortest one, and I draw a line perpendicular to my long axis and measure down 3 millimeters, right about there. That's as close as I can expect to get those gums. Well, great, I've got them here, I'd like to get them closer. So I can do gum surgery here, do a graft. I like alloderm. Some people like to use tissue off the roof of the mouth. If I do need the donor tissue from the patient, I always get it from the back where the third molars were on the maxillary arch. I want that tuberosity tissue. Patients don't mind it nearly as much. You start harvesting palatal tissue, everybody hates you for a good long time after that. I do both. 95% of what I do is alloderm, though. I'll do both human tissue from them, from the tuberosity, or alloderm. Most of the time it's alloderm. So we'll do a graft up there and get it. If your doctor likes to do grafting, then this is a good protocol to understand. If not, then no one to refer out. But don't refer it out to a periodontist when the right treatment is to restore the teeth. Makes a lot of sense, I think. Here's just a fun one. This is a girl, a young lady who was a patient of mine for many years, and I kept saying, you ought to have some grafting done. Finally, she acknowledged it when she was in her 40s, I guess, and said, sure, I'll do it. And I knew her since she was in her 20s. Here's just 6 weeks after. This is all alloderm. I did the work myself, all alloderm grafting. You look at how good, I mean, go back. Look at how cratered out some of these things were, how far. But she had good scalloped borders in terms of the periodontium, so I knew I'd have a good result with just Alloderm. There's 6 weeks, there's 1 year, and there's 9-year follow-up. I just took that a year or two ago. Again, everything stayed in place. So Alloderm is wonderful, and if you do it yourself, but you're using palatal tissue, think about Alloderm instead. Probing depths. This is just up to you guys. I'm not going to give you a firm answer here. This is whatever is best in your wheelhouse. I would go in and treat it non-surgically, probably periodontal therapy with a laser and a good scaling, and then inject some something up in there, some minocycline tablets or whatever your choice of medicament is. But that's up to your office. You just have to know what your doctor's comfort level is on treatment in office, whether surgical or non-surgical, and when to refer out. Some dentists refer out all perio, and that's fine, but that's a referral case. You got deep probing depths. The bonus question, 65 years old, second visit to our office in 2 years. I don't have a good history on this. There's no symptoms. What do you want to do about that tooth? I didn't give you a list of choices because the right answer is I need more information. That looks a little bit suspicious, but that's a one snapshot in time. I'd like to go back and look at some old x-rays, or maybe wait 6 months and look at it again to see if there's any progression of that. It looks like it's maybe filled with bone, or maybe could be a slight PAP forming. No symptoms, no blown out abscess, no decay. Well, my answer is I want more information. Maybe even just a different angle of x-ray. So here's another x-ray with a slightly different angle. Now that's starting to look a little bit more like a bone loss. And again, looks a little more like bone loss there. Today, now, I'll take a CT scan of that. We'll do a CBCT in my own machine, and this was prior to our CBCT, but I know right now I'm going to find a nice abscess there, and I'll be able to look inside the canals and see if they're treatable or not on someone with that much condensation of the dentin. Here's some fun, just as we round out things. What tooth is this? Well, I'll tell you, he was born as number 18, but he leans so far to the left that he identifies as 19. Political humor. Here, let's count all the teeth from the back forwards. Here we got 18, 20, 19, 20, 21. I don't know what the heck is going on there. There's a supernumerary premolar that looks pretty well positioned. It's not primary. The x-rays showed me that. Funny stuff you see in the mouth. This is really fun. What tooth number is this? If you were alive and you were a teenager in the 70s, you probably got the answer. That's the Mr. Bill tooth, because it looks just like Mr. Bill. If you don't know that, ask someone who's older than you. And when you don't floss, we bring out the tickler. So fun stuff. That's the conclusion of Module 5. I hope you enjoyed it. If you would like printed copies of the test part, please just email us, let us know. It should be as an electronic attachment to however you got this, or it should be on my website somewhere. You find it or call us, we'll make sure we get it to you. It's a fantastic communication tool. Do it with your doctor, have a lot of discussion about it. My preference is that you would develop this on your own. You or your doctor would take slides of all the same kind of work in your own patients, especially for the things that maybe you're having difficult communicating about, when to crown, when to fill, and then figure it out. If you want to be a little more sneaky about it, be careful. You better be pretty secure in your job. When you see a tooth that you think needs a crown, hygienist, and your doctor comes in and says, nah, it's fine, take a picture of those teeth. Wait a few months. Put them all together in a page, a few pages or a presentation, and say, doctor, let's communicate about this. What would you do for this tooth? When he looks at it close up, he'll probably change his mind and go, oh my gosh, we should crown that. And then you can say, well, you decided not to. You better be really secure in your job, and you better make it a learning experience, not an I told you so experience, because smugness never works, but team building does. And that's what we're all about. Team building, why? Better customer service. Thanks for watching.